My name is Brittany Ragon, and I am a leukemia specialist at Levine Cancer Institute in Charlotte, North Carolina. I will be presenting to you highlights from my recent publication in the American Journal of Hematology regarding minimal residual disease eradication using epigenetic therapy and core binding factor acute myeloid leukemia. This was a single institution investigation performed at MD Anderson Cancer Center in Houston, Texas. As you may know, core binding factor AML is an acute myeloid leukemia defined by the presence of translocation 821 or inversion 16. This diagnosis represents 15% of all AML and has a favorable prognosis when treated with intermediate to high-dose cytarabine regimens. The cure rate in these patients is greater than 65%, with just chemotherapy alone. However, in about 20 to 25% of patients, disease relapse is the major cause of treatment failure, and this presents a significant concern in an otherwise curable disease. Real-time quantitative polymerase chain reaction, or RTPCR techniques, now allow for the detection and quantification of leukemia-associated genes to measure minimal residual disease. Detection of minimal residual disease is moving to the forefront of prognosticating patients following induction therapy and guiding post-remission strategies, including who might benefit from allogeneic stem cell transplantation. Routine monitoring of MRD and core binding factor AML is a method to monitor for relapse and provide dynamic risk stratification while on therapy. There have been several efforts to quantitatively define the MRD level that might signify overt relapse and necessitate salvage therapy. Persistent elevation of RTPCR transcript and core binding factor AML portends a higher risk of relapse. In addition, concomitant mutations along with translocation 821 and inversion 16 have been associated with a higher risk of relapse. Concomitant mutations in c-KIT and FLT3-ITD are also of interest as they have impacts on relapse-free, event-free, and in certain situations, overall survival. In our analysis, we explored concomitant mutations to identify what impact this might have on MRD status and further therapy. With this wealth of information regarding the importance of MRD and core binding factor AML, an important question remains. What should we do when a patient is in morphologic remission but has persistent MRD positivity? What is known is that hypermethylation of certain genes when patients are in remission has been associated with increased likelihood of relapse in AML. Promoter hypermethylation of tumor suppressors is frequently seen in core binding factor AML. It is hypothesized that hypomethylating agents such as decitabine or azacitidine can potentially reverse such epigenetic silencing. Significant survival improvement has not yet been shown with an HMA maintenance strategy, but certainly clinical benefit has been observed. The use of MRD-directed HMA maintenance therapy has not been extensively explored. Our hypothesis was that HMA maintenance therapy could be used to target residual low-level PCR positivity and potentially eliminate MRD to ultimately prolong relapse-free survival in core binding factor AML. This was a retrospective analysis performed at MD Anderson Cancer Center. Patients were identified as having core binding factor AML with evidence of either translocation 821, inversion 16, or translocation 1616 with or without additional cytogenetic abnormalities. Patients who were enrolled on NCT 00801489, which was a phase 2 study of fludarabine, cytarabine, filgrastim, and idarubicin in newly diagnosed core binding factor-associated AML, who then went on to receive at least one cycle of HMA maintenance therapy following completion of induction or consolidation, were included in this analysis. 23 patients were identified between August 2008 and April 2015. RTPCR from peripheral blood or bone marrow was obtained approximately every 3 months per protocol. The sensitivity of detection for transcript RT-PCR at the time of this analysis was between 1 in 10,000 and 1 in 100,000. Mutations in KIT, FLT3-ITD, FLT3-D835, and RAS genes were tested at baseline. In addition, most patients were evaluated for NPM1, TP53, IDH1, and IDH2 mutations at baseline. The treatment regimen is shown here. Patients transitioned to HMA therapy and received monthly maintenance with decitabine 20 mg/m² on days 1 through 5, or azacitidine 75 mg/m² on days 1 through 5. This was repeated every 4 to 5 weeks based on count recovery and toxicity. 23 patients were evaluated in this analysis. The median age was 53. Most patients had inversion 16 at 65%, with 35% with translocation 821. All patients were noted to be in a morphologic CR based on a bone marrow blast percentage of less than 5% at the time of HMA initiation. Patients went on to receive HMA maintenance due to persistent PCR positivity in about 57% of cases, but prolonged myelosuppression and molecular relapse after stem cell transplant were also reasons documented for proceeding to HMA therapy. Reason for transition to HMA therapy was according to what was documented in the patient's chart at that time. Most patients received decitabine, with 2 receiving azacitidine, mostly based on physician preference. The median follow-up at the time of this analysis was 11.3 months. A median of 6 cycles of flag-based induction and/or consolidation was administered. HMA maintenance therapy was provided with a median duration of 6 cycles. At the time of HMA initiation, 17 patients had detectable MRD with an RTPCR greater than or equal to 0.01. These 17 patients became the focus of the rest of our analysis. 6 patients had no detectable MRD at HMA initiation and remained with no evidence of MRD and in remission. For all patients, including the 17 of interest, all were observed to be in complete morphologic remission. Patients were further classified as responding to HMA maintenance or failing HMA maintenance. Failure was assigned if the patient was taken off HMA therapy for evidence of disease progression. Here you see the RT-PCR values over serial measurements for the HMA responders on the left and HMA failures on the right. Of these 17 patients, 5 patients had progressive disease post-HMA initiation, including 1 with translocation H21 and 4 with inversion 16. The RT-PCR values preceding HMA in these 5 patients were 3.84, 0.06, 0.08, 0.01, and 0.01 respectively, with a median of 0.06. All 5 patients had a log increase in the RT-PCR value after 1 to 2 cycles of HMA, as noted on sequential RT-PCR. RT-PCRs for these 5 patients following the first or second cycle of HMA were 51.67, greater than 100, 77.48, 1.33, and 0.17 respectively. RT-PCR transcript levels measured after first or second cycle of HMA maintenance therapy in this failure group taken as an aggregate were significantly greater than transcript values in the HMA responders, with a p-value of 0.01 based on a Mann-Whitney test. Of note, all 5 patients failing HMA proceeded to SCT, or stem cell transplant, and 3 are alive and disease-free post-stem cell transplant with a median follow-up of 11 months. 2 of the 3 surviving HMA failure patients had undetectable MRD following SCT. As of last follow-up, 1 surviving patient from the HMA failure group had a detectable RT-PCR of 0.02, and reinitiation of maintenance therapy with azacitidine was planned. For the 12 patients who did not fail HMA, the median RT-PCR at HMA initiation was also 0.06. Unlike the HMA failure subset described, 11 of these patients had a reduction in RT-PCR after the first or second cycle of HMA. 1 patient was in early follow-up. These 12 patients remained in morphologic and cytogenetic complete remission as of last follow-up. Of the 23 patients reviewed in this analysis, only 2 deaths occurred between August 2008 and April 2015. These 2 deaths occurred in the HMA failure group, 1 from leukemia relapse and 1 from stem cell transplant complications. There is, not surprisingly, a survival difference between HMA responders and HMA failures, shown here, with a p-value of 0.03. 8 out of the 23 patients remained on HMA therapy at the time of last follow-up. And briefly regarding mutational analysis of the patients in this investigation, of the 5 patients failing HMA, 4 had a RAS mutation detected, with additional mutations listed here. Of the 12 patients who responded to HMA, 4 had a RAS mutation, 1 with concomitant FLT3 ITD, 3 were KIT mutated, and 1 with a FLT3 D835. Of the 6 patients who proceeded to HMA maintenance without detectable MRD, only 1 patient had a coexisting FLT3 D835 mutation. All other mutations assessed were negative at diagnosis. In the HMA failure group, 80% of patients had a coexisting mutation. For those who responded to HMA maintenance, 67% carried a concomitant mutation. Overall, this distribution of co-occurring mutations is concordant with the typical distribution seen in core binding factor AML. With a small number of patients in this analysis, the impact of coexisting mutations on the efficacy of HMA maintenance therapy cannot be adequately determined. However, notable, only 1 of 6 patients who proceeded to HMA maintenance without detectable MRD had coexisting mutations, suggesting that mutation burden might contribute to persistent MRD in core binding factor AML. This investigation was performed because we recognize that MRD positivity in core binding factor AML is something that providers will see in practice, and the guidelines are not clear on what to do in this situation. Thus far, we have recognized that detection of MRD portends a higher risk of relapse in core binding factor AML, but we have not established how best to handle MRD positivity in this population. Although this analysis is limited by the sample size and exploratory nature, and further limited by not predefining levels of MRD required for initiation of HMA therapy, it is revealed that HMA maintenance can be used as a treatment strategy in MRD-positive core binding factor AML patients after induction and consolidation. In this population, patients with low levels of RT-PCR between 0.01 and 0.05 at the conclusion of induction consolidation chemo derive the most benefit from maintenance HMA, particularly those with a reduction in the RT-PCR within the first 2 cycles of HMA therapy. We propose this population be explored further in future studies of HMA maintenance and core binding factor AML. We recommend future investigations explore the role of concomitant mutations with a maintenance HMA strategy, as mutational burden might play a role in refractory disease. A well-designed clinical trial with predefined MRD levels and mutational monitoring over time will provide improved guidance in utilizing maintenance therapy and core binding factor AML. You are welcome to review our publication in the American Journal of Hematology for further details, and I thank you for your attention.